Hello, thank you very much to the Society for having me. My name is Peter Douglas. I'm a radiologist from Glasgow. I'm going to speak today a little bit about peripheral MR angiography. Now, I think most of the talk this afternoon could be divided into two sections. Why should we image and how should we do it? And I'll cover both of those very quickly, with the caveat that I'm only going to be talking this afternoon about contrast-enhanced MRA. I'm very much looking forward to some of the talks in the rest of the week about the non-contrast techniques, including the advances in KISS. So atherosclerosis is by far the biggest indication for imaging the peripheral arteries of the lower limb. Embolism, trauma, and others do make up a significant percentage, although much smaller. They can all be grouped into anything which compromises the blood supply to the lower limbs. But again, ischemia of the lower limbs is not the only reason for imaging. The assessment and follow-up of vascular malformations, planning of reconstructive surgery. The plastic surgeons are doing more and more free flap repairs, and detailed arterial assessment is key to ensure that flap survives post-surgery. And then critically, to diagnose the cause of limb ischemia and plan the intervention, because we don't take pictures just for the sake of taking pictures. We take them so that we can work out what's wrong and actually do something about it, and that's what I'm interested in, planning the interventions. So the two disease patterns in the vast majority of people who present with ischemic symptoms of the lower limbs are intermittent claudication, pain on walking a fixed distance. This tends to be aortoiliac and or femoral level disease. It can be stable over years and is life-limiting but not necessarily limb-threatening. The mainstay of treatment is lifestyle modification. However, critical limb ischemia presents with either rest pain or tissue loss. They almost invariably have tibial disease, often along with complicated aortoiliac and femoral disease, and by definition these people have limb threat. The tissue loss can be relatively minor, like this ulcer, or more extensive gangrene. And this leg has to come off. The whole purpose of imaging these arteries is to try and prevent these legs needing to be amputated and to keep your patients ambulant. And there's a mortality associated with amputation for this indication as well. So other non-invasive imaging modalities are available. Ultrasound gives very high resolution and some very helpful flow information, but it gives very poor views in many areas. It's time consuming and it's very dependent on the skill of the operator. CT is fast, it's reproducible, it's accessible everywhere, but it's extremely poor for the small calcified vessels in the crural vessels, and especially into the foot, which are particularly important. So there are 4 points I would like anyone who's interested to take home from this talk today. One is that if you want to do good quality MRA, then patient comfort is key. 2, the need for dynamic imaging to avoid venous overlay. 3, the coverage of the plantar arch and why that's critically important. And the role of high resolution imaging and MR venography. So preparation, patient comfort is absolutely key. Most of these patients are in pain. The pain is worse on elevation of the affected limb. That's further exacerbated by placing coils on top of the limb, and although that's better these days as coils are lighter and lighter, despite that, the patients need to lie still for at least half an hour in order to get this, and they have to really stay still and not move. Analgesia is a solution to this. So your inpatients should have analgesia prescribed on the ward before they come down. Outpatients can bring analgesia with them. Or if you have the facility to administer analgesia in the department, then I suggest you use it. I'm lucky to be young enough to not have practiced in the day of single station non-moving MR angiography. Image quality has always been very good, and what we've really added with table motion is the ability to cover more of the patient. I'm still using a multi-station bolus chase MRA. There is the option of continuous table movement, but it's not something I have experience with. So how do I do a peripheral MR angiogram? I do dynamic tibial station imaging, and a conventional 3-station moving bed bolus chase MRA, or 4-station can also be used, and then high resolution steady state or equilibrium phase imaging of the thighs and the leg. So I've got a Siemens scanner, so I use twist following an infusion of Gadavist. Then we take our mask images, We then use MR fluoroscopy over the aorta as the gadolinium is being infused, and that triggers the standard 3-station angiogram. And following that, we do our high resolution imaging. It takes around 4 minutes or so, and there's a further infusion of a small volume of Gadavist at this point. All of these need good quality saline chases to push them through all the way down to these small vessels. And this is the sort of imaging quality that you can expect. Your temporal resolution is more important. You can compromise on your slice thickness. About 2 millimeters will be absolutely fine. Our aortic, femoral, and tibial stations look a bit like this. And here is some of the excellent anatomical detail that you can get with your high resolution images of these very small arteries and veins below the knee. This works very well in the vast majority of patients, particularly those with claudication. And you don't tend to get many issues with that. However, once people start to get tissue loss, ulceration, and infection sets in, you get a lot of venous overlay or venous contamination. This hugely limits your ability to accurately interpret the angiogram more distally. And why does that happen? Well, the normal contrast travel times are around 6 seconds per station, but with vasodilatation in the ischemic limb, any sign of cellulitis at all, there's AV shunting and a very rapid transit time between the artery and the venous phase. It's extremely difficult to get a good quality 3-station angiogram, and time-resolved imaging is the solution to that. Now, all angiography is a trade-off between spatial resolution and the time of acquisition, and of course, as has been already said today, time-resolved imaging prioritizes the temporal resolution over the spatial resolution. The parallel imaging techniques and view sharing, case-based sampling has already been described, but just to quickly cover it again, we obtain a mask beforehand, then we infuse our gadolinium, we rapidly sample the center of case base preferentially in order to get that high contrast information, to get good luminal detail. Then we can share the peripheral edge information from multiple different acquisitions and subtract that from our mask to create these very nice time-resolved DSA type images. And this even shows some early venous filling up the short saphenous vein on the right. You can see how quickly that transits through, and this patient will almost certainly have a very extensive venous overlay on the tibial angiogram. And these are the sort of images that you can achieve. We routinely knit these together for the vascular surgeons. You can see the artifact in the area where the 3 stations have been overlapped together over the common femorals and the proximal popliteal and adductor canal. Unfortunately, that coincides with some of the areas that are predisposed to atherosclerotic disease in the common femorals and the adductor canal. And this is one argument for doing a 4-station angiography, widening the region of overlap to try and minimize this sort of artifact. Now, some people advocate using standard 3 stations and using the same coverage for your tibial station for your time-resolved imaging. I don't do that. I don't advocate doing that at all, and I would strongly suggest, if at all possible, to center your time-resolved acquisition as low as you can get it to try and get good detail of the plantar arch. Now, the plantar arch is a fairly small artery, but it is the final common pathway for blood going into the toes. More than that, there's a growing body of evidence to say that integrity of the plantar arch in patients with critical limb ischemia is the strongest single determinant for limb salvage. And if it's occluded, then either myself or one of the vascular surgeons needs to go in and recanalize it if they're to massively improve the rate of limb salvage in that patient and try and keep the leg attached. Now, high resolution imaging, why is it worth doing if the other angiograms are so good? Well, In patients with heart failure, it gives you a second chance for arterial assessment if the contrast bolus hasn't quite reached the peripheries at the time you've imaged. It gives fantastic vessel wall detail that you lose with some of your subtracted imaging. It demonstrates plaque morphology very nicely, and I'll talk in a minute about how that's helpful. And you get a free MR venogram. Now, venous bypass surgery is the mainstay of treatment in patients with severe femoral disease, and the vascular surgeons need to know the quality and the caliber of the veins that they're going to be using to make sure that they can create a fempot bypass that's going to be durable and sufficient to maintain limb salvage. This can be assessed with ultrasound, but it's time consuming. And while they're on the scanner and they've already had gadolinium in, just for another few minutes of scanning, you can get absolutely lovely images. They're very easy to measure and gives the surgeons all the information they need. And the other reason is DVT. So up to 10% of patients with critical limb ischemia have coexisting venous thrombosis. They have a procoagulable state, which has contributed to their arterial occlusion in the first place. That combined with stasis and immobility is thought to create this high rate of DVT. And this is the sort of high resolution images that we can get with a standard kind of flash type acquisition. This is a 0.5 isovolumetric acquisition, and you can see fantastic detail right down to individual valves within these tibial veins. Is that absolutely necessary to see that level of detail? You could argue no, but if our vascular surgeons are going to do a femdistal bypass and suture a vein onto this 2 millimeter anterior tibial, they need to know that the arterial wall in that area is free of significant calcification to make sure they can complete the surgery. Now, high-resolution imaging also allows plaque morphology assessment, and again, there's a growing body of evidence to say that assessing the plaque morphology is very valuable in determining whether or not you're going to be able to cross this lesion endovascularly in an antegrade approach, or whether you're going to have to take a retrograde approach and puncture the dorsalis pedis or posterior tibial artery and crack through the plaque from the foot heading upwards, or using combined techniques. And it helps you counsel the patient before the procedure if you know that. I'll speak very briefly about Dixon imaging in MRA. It's been covered before, the physics of it, using the 2-point or multi-point methods to give excellent fat suppression. The Dixon method from Philips also allows shorter echo times and TRs, which can reduce the acquisition time in total. Why is that important? Well, if you skip your mask section and you can reduce your angiogram time, the patient's on the table for less time. They're more comfortable and they will be able to stay still. You'll get a better quality angiogram, and you'll be able to give more information to your surgeons and interventional radiologists to try and keep that leg attached and healthy for longer. And you can see excellent fat suppression. If it's not a technique that you've used a lot, then I would recommend at least acquiring all of the 4 images available for Dixon to look out for fat water swapping, although I think that's a lot less of a problem these days than it previously was. So in summary, I hope you are now able to take away those 4 key points of why patient comfort is key, the need for dynamic imaging to avoid venous overlay, why coverage of the plantar arch is important because it is the single largest determining factor for limb salvage, and the role of high-resolution imaging for vessel wall detail and for MR venography. Thank you all very much.